I want you to think about something you did this morning. You were sitting in a chair, at the kitchen table maybe, or in the armchair where you have your coffee, and at some point you needed to get up, and it was harder than it used to be. Maybe you used the armrest. Maybe you shifted your weight forward first, rocking slightly before you pushed off. Maybe there was a moment, just a second or two, where your legs felt uncertain underneath you, where the act of standing, something you have done without thought for 60 or 70 years, required conscious effort. You filed it away. You told yourself it was the chair, or that you had been sitting too long, or that this is simply what getting older feels like. I am Dr. Amelia Carter. After 20 years as a cardiac surgeon, I have sat across from hundreds of patients who said exactly those words. It's just age. And in case after case, those three words were doing something very specific. They were closing the door on a question that deserved to be asked. Because difficulty rising from a chair is not a furniture problem. It is not a posture problem. And it is not simply the inevitable arithmetic of getting older. In adults over 60, progressive difficulty getting up from a seated position is one of the earliest visible signs of a process that is happening simultaneously in your muscles, your arteries, and your nervous system. A process that has a name, a mechanism, and, if it is caught at this stage, a meaningful set of interventions that can slow, stop, and in some cases partially reverse what has been building quietly for years. The problem is that nobody connects those things. Your doctor sees the difficulty and thinks orthopedics. Your physiotherapist thinks muscle weakness. Your cardiologist is not in the room at all. And you, the person who has to get up from the chair every single morning, have been given a shrug and a reassurance that amounts to, welcome to your 70s. I am not going to tell you the name of what this is yet, not because I want to delay the answer, but because if I name it now without showing you the mechanism, it will sound like a single problem with a single solution. It is not. It is a system. And understanding the system is what makes the difference between a treatment that works and a treatment that is applied to the wrong part of the picture. Stay with me. What I am about to show you is the most complete clinical picture of this symptom that you will find outside of a specialist's office. And by the end of this video, you will know something your GP almost certainly has not had time to tell you. I want to tell you about a woman named Gloria. Gloria is 68 years old. She is a retired school librarian. She has 2 dogs and a garden she has tended for 30 years. She came to see me not because of her heart. Her last echocardiogram had been unremarkable. She came because her daughter had insisted. Her daughter had visited 3 months earlier and watched her mother try to get up from the sofa. She had watched her grip the cushion with both hands, shift forward twice, and push herself upright with visible effort. Her mother was 68. Her mother had been walking those dogs every morning until the previous spring, and her daughter had seen that sofa-rising moment and felt something cold in her chest that she could not explain. Gloria herself was unconcerned. "It's just my knees," she told me, "and my hips have never been great, and honestly, that sofa is too low." I asked her 3 questions. Was the difficulty getting worse, or had it been the same for a few years? She said, worse, gradually, over about 18 months. Had she noticed any change in her legs when she walked? Heaviness? A feeling of working harder than the distance warranted? She paused. Actually, yes, but I thought that was just fitness. Had anyone measured the strength in her thigh muscles recently? Nobody had. We will come back to Gloria, because what her tests revealed, and what changed in the months after, is the resolution this video is building toward. But I am not going to tell you yet. Because first you need to understand what was actually happening inside her body, and that understanding is going to require me to take you somewhere most health content never goes. Before I do, I want to be direct with you about what this video is and is not. This is not a video about exercise. It is not about which chair is the right height. It is not a reassurance that difficulty rising from a chair is normal and manageable with a few stretches. This is a video about what difficulty getting up from a chair actually means medically, the 3 physiological systems it implicates, the specific tests that can tell you which system is most involved, and the clinical framework that determines which intervention, not which exercise, but which medical and lifestyle intervention, is appropriate for your specific picture. I am going to ask you to do one thing as you watch. Think about the trajectory. Not just whether you have difficulty rising from a chair today, but whether that difficulty is the same as it was 2 years ago. The trajectory is the clinical signal. The trajectory is what tells you whether the system is stable or progressing. There are 3 types of people watching this right now. The first type has noticed some difficulty getting up, but attributes it entirely to a specific structural problem. A bad knee, a replaced hip, an old back injury. There may be truth in that. But I want you to stay, because the structural problem and the systemic problem can coexist, and treating only the structural one while the systemic one progresses is a very common and very costly mistake. The second type has been noticing a gradual, unexplained worsening over the past 1 to 3 years. No new injury, no clear orthopedic diagnosis, just a progressive sense that the legs are not what they were. This video was made for you. Please do not leave early. The third type has someone in their life, a parent, a spouse, a sibling, who they have watched struggle to rise from a chair. You have worried about it quietly. You have perhaps mentioned it and been dismissed. What you are about to learn will give you the language to have a different conversation. To understand what rising from a chair actually requires, you have to understand something that is almost never explained to patients. It is one of the most mechanically demanding movements a human body performs in the course of an ordinary day. Think about what happens in the 2 seconds it takes to stand up. Your quadriceps, the large muscles at the front of your thighs, must generate enough force to lift your entire body weight from a position of mechanical disadvantage with your hips flexed and your torso leaning forward. This requires the quadriceps to produce a force equivalent to roughly 2.5 to 3 times your body weight across the knee joint. In a 70-kilogram person, that is 175 to 210 kilograms of force generated in under a second. Your cardiovascular system must simultaneously redirect blood flow. When you sit, blood pools in the lower limbs due to gravity. When you stand, your heart and peripheral vasculature have to compensate rapidly to maintain cerebral perfusion. Blood flow to the brain. If that compensation is slow or inadequate, you feel dizzy. You reach for the armrest. You hesitate at the top of the movement, and your nervous system must orchestrate the entire sequence. The timing of muscle activation, the postural adjustments that keep you from falling forward, the proprioceptive signals that tell your brain where your body is in space. Any degradation in peripheral nerve conduction speed slows this coordination. The movement becomes effortful. It looks labored from the outside because it is effortful from the inside. 3 systems: muscles, cardiovascular, nervous system. And here is the clinical reality that your annual physical almost never addresses. All 3 can degrade simultaneously in adults over 60, driven by a single underlying process, while each individual system appears to be within the normal range for age when tested in isolation. The degradation is real. The impairment is real. The test says, within normal limits for your age, and you are left with a shrug and a chair that is apparently the wrong height. I want to show you what is actually driving the degradation in each of those 3 systems, because when you understand the driver, you will understand why treating the knee, or changing the chair, or doing leg raises 3 times a week is addressing the symptom and not the source. And I want to show you something else. I want to show you that the driver of all 3 degradations is not irreversible aging. It is a specific, measurable, modifiable process. And the earlier it is identified, the more of your function is recoverable. Let me take you through each system. The muscle system, sarcopenia, and its driver. After the age of 50, adults lose on average 1 to 2% of their muscle mass per year. That number sounds small. Over 10 years, it is 10 to 20% of the muscle that carries you through your day. Over 20 years, it is the difference between independence and dependency. This process is called sarcopenia. and the word is used so loosely in popular health content that it has almost lost its clinical meaning, so I want to give it back. Sarcopenia is not simply the result of reduced activity. Activity matters. I will get to that. But inactivity alone does not explain the rate or the distribution of muscle loss in most seniors. The primary driver is a failure of muscle protein synthesis. Here is what that means. Your muscle tissue is in a constant state of turnover. Old protein fibers are broken down, new ones are synthesized to replace them. This balance is regulated by hormones, by nutrient availability, and by something called anabolic sensitivity, how responsive the muscle cell is to the stimulus for growth. In young adults, this system is efficient. In adults over 60, anabolic sensitivity declines. The breakdown continues at its normal rate. The synthesis slows. The net result is progressive muscle loss even in people who are reasonably active and eating adequate protein. But there is something else driving the muscle loss that almost nobody discusses in patient-facing terms: chronic low-grade inflammation. In adults with early cardiovascular disease, insulin resistance, or simply the accumulation of visceral adipose tissue that comes with metabolic aging, circulating inflammatory markers, particularly a molecule called interleukin-6, directly suppress muscle protein synthesis. The inflammation is not severe enough to cause symptoms on its own. It is subclinical. It does not show up as pain or swelling. But it is measurable in a blood test that most standard panels do not include, and it is quietly accelerating the muscle loss that makes getting out of a chair harder every year. This is the connection between your cardiovascular health and your leg strength that nobody puts in the same sentence. The cardiovascular system: microvascular insufficiency in skeletal muscle. Your muscles need oxygen to produce the force required to lift your body. Oxygen arrives via the arterial system. In adults with atherosclerosis, the gradual narrowing of arteries from plaque accumulation, the delivery of oxygen to working muscle is impaired not just in the large vessels, but in the small arterioles and capillaries that feed individual muscle fibers. This is called microvascular insufficiency, and it does not produce the dramatic claudication, the calf cramping at a predictable walking distance, that most people associate with peripheral arterial disease. Microvascular insufficiency produces something more subtle, a fatigue that arrives earlier than it should, a heaviness in the thighs during activities that used to feel effortless, a recovery time after exertion that has lengthened without any obvious explanation. Think of it this way: every muscle fiber in your thigh has its own tiny blood supply. In a well-perfused muscle, when that fiber contracts, oxygen arrives within milliseconds. In a muscle with microvascular compromise, there is a lag. The fiber contracts, but the oxygen delivery is delayed. The fiber fatigues faster. You feel that as effort, as the sense that your legs are working harder than the task requires. What makes this clinically important is that microvascular insufficiency in skeletal muscle and microvascular insufficiency in the coronary circulation, the small vessels feeding your heart muscle, are driven by the same process: systemic endothelial dysfunction, a deterioration of the inner lining of blood vessels across the entire vascular tree. The legs are, again, the first place this becomes functionally visible. The legs are the canary. The nervous system: peripheral nerve slowing and motor unit loss. Muscle strength is not just a function of muscle mass. It is a function of the nervous system's ability to recruit and coordinate muscle fibers. This requires fast, accurate nerve conduction from the spinal cord to the muscle and a sufficient number of intact motor units, each a single motor nerve and the group of muscle fibers it controls. After the age of 60, adults begin to lose motor neurons from the spinal cord at an accelerating rate. This is a normal feature of aging, but its rate is highly modifiable. The motor neurons that are lost are not replaced, but the remaining motor neurons can, under the right stimulus, expand their territory by sprouting new connections to the orphaned muscle fibers. Exercise, specifically resistance exercise, is the primary stimulus for this compensation. In sedentary seniors, this compensation does not occur. The motor units shrink, the force output declines, the coordination of the movement becomes imprecise. And the proprioceptive signals, the feedback from the muscles, tendons, and joints that tells the brain where the body is in space, becomes slower and less accurate. The wobble at the top of rising from a chair is not weakness alone, it is imprecision in the nervous system's real-time map of the body. Now, I want to ask you something directly. Have you ever had all three of these systems assessed together at the same appointment? Muscle mass measured, not estimated. Vascular function assessed below the waist. Nerve conduction or motor unit integrity evaluated. For the vast majority of seniors watching this, the answer is no. And that absence of integrated assessment is the specific failure this video exists to address. What I want to give you now is the clinical map, the specific tests, what each one measures, what a concerning result looks like, and how to have the conversation that turns these tests from abstract possibilities into actual appointments. Test 1. The chair stand test. 30 seconds. This is the most clinically validated test of lower extremity muscle power in seniors, and it takes 30 seconds to perform. It requires a standard straight back chair with no armrests or your own chair with your arms folded across your chest. Set a timer for 30 seconds. Sit in the middle of the chair, feet flat on the floor, arms crossed on your chest. On start, rise to a full standing position and sit back down as many times as you can for 30 seconds. Count the complete stance. Here are the reference values for interpretation. These are age-adjusted normative data from the Tufts University Senior Fitness Research. Women aged 60 to 64. 12 stands or more is normal. Below 10 warrants evaluation. Women aged 65 to 69, 11 or more normal. Below 9 warrants evaluation. Women aged 70 to 74, 10 or more normal. Below 8 warrants evaluation. Women aged 75 and over, 8 or more normal. Below 6 is a significant finding. Men aged 60 to 64, 14 or more normal. Below 12 warrants evaluation. Men aged 65 to 69, 12 or more normal. Below 10 warrants evaluation. Men aged 70 to 74, 12 or more normal. Below 10 warrants evaluation. Men aged 75 and over, 10 or more normal. Below 8 is a significant finding. If you are below the threshold for your age and sex, that is not a diagnosis. It is a referral trigger. It tells you and your doctor that lower extremity function warrants formal assessment. Write your number down before you continue watching. Test 2. The ankle brachial index. You have almost certainly never had this test. It is not included in standard annual physicals. It takes 4 minutes. It requires the same blood pressure cuff your doctor already has. And it is the single most accessible screening tool for peripheral arterial disease that exists in clinical medicine. The ankle brachial index compares the systolic blood pressure at your ankle to the systolic blood pressure at your arm. In a healthy arterial system, these pressures should be approximately equal. When arteries are narrowing, pressure drops downstream of the narrowing. An ankle pressure that is significantly lower than arm pressure means the arteries between the heart and the ankle are compromised. An ABI of 1.0 to 1.4, normal. An ABI of 0.9 to 1.0, borderline. Mild disease may be present. An ABI below 0.9, peripheral arterial disease is present. An ABI below 0.7, moderate to severe disease. Further imaging is indicated. The connection to rising from a chair is direct. Muscles fed by compromised arteries fatigue faster, recover slower, and cannot sustain the force output that the movement demands. An ABI below 0.9 in a senior with progressive difficulty rising from a chair is a finding that connects those two observations clinically, and it changes the management conversation entirely. Test 3. Hand grip strength. The whole body proxy. This seems counterintuitive. You are having difficulty with your legs. Why would anyone measure your hand? Because hand grip strength is the most extensively validated proxy for whole body muscle mass and systemic muscle function in the research literature. A 2015 Lancet study of 140,000 people across 17 countries found that grip strength was more predictive of cardiovascular mortality than systolic blood pressure. not as predictive, more predictive. The reason is that grip strength reflects the overall state of the motor unit system throughout the body. The same neuromuscular processes that determine quadriceps power determine grip strength. They decline in parallel. And grip strength can be measured in 30 seconds with a hand dynamometer, a device that costs $30 and is available in most sports medicine offices. For women over 65, a grip strength below 18 kilograms is considered low. For men over 65, below 30 kilograms. Below these thresholds, the risk of adverse health outcomes, including falls, hospitalization, and cardiovascular events, is significantly elevated. If your doctor has never measured your grip strength, ask them to at your next appointment. Ask by name, hand grip dynamometry. Test 4. The inflammatory panel. I mentioned earlier that chronic low-grade inflammation is one of the primary drivers of muscle protein synthesis failure in seniors. This inflammation is measurable. It does not require a specialist referral. The markers can be added to any standard blood draw. High-sensitivity C-reactive protein, or hsCRP, is the most accessible marker of systemic inflammation. In adults without acute illness, an hsCRP above 3 mg per liter is associated with elevated cardiovascular risk and is consistent with the kind of chronic low-grade inflammatory state that accelerates sarcopenia. Interleukin-6, if your practice can order it, is a more specific marker for the inflammatory pathway that directly suppresses muscle protein synthesis. Serum albumin below 3.5 grams per deciliter indicates protein nutritional deficiency, which in seniors is a significant independent contributor to muscle loss. None of these tests are exotic. None require specialist referral. All can be ordered by a GP. And together, they tell you whether the inflammatory and nutritional environment inside your body is one that supports or undermines muscle maintenance. I am going to tell you about Gloria's results in a moment. And then I am going to give you the complete framework for your own appointment, the tests to request by name, the numbers to watch for, and the exact language that will transform this conversation from "it's probably just age" into a specific, documented, monitored clinical picture. But first, I need to show you what meaningful intervention actually looks like at this stage, because I want you to understand what is recoverable before you receive your own results. The answer is more than most people have been led to believe. Peripheral arterial disease, caught before claudication. Sarcopenia, caught before falls. Motor unit loss, caught before the point of irreversibility. At this stage, the stage where the symptom is difficulty rising from a chair and not yet hospitalization from a fall, the body retains substantial capacity for adaptation. I want to give you this picture clearly because the medical conversation around age-related decline is saturated with therapeutic nihilism. The implicit message, delivered through shrugs and pat reassurances, is that this is the road you are on, and the best you can do is manage its gradient. That is not what the evidence says. Intervention 1. Progressive resistance exercise. The non-negotiable. I use the word non-negotiable deliberately. If there is one intervention that the research supports unequivocally for every system involved in rising from a chair, it is progressive resistance exercise. Not walking, not yoga, not aqua aerobics. Resistance training, exercise that requires your muscles to work against a load that increases progressively over time. The mechanism for each system is distinct. For sarcopenia, resistance training is the only stimulus that reliably activates the mTOR pathway, the molecular mechanism responsible for muscle protein synthesis. It does this even in the presence of age-related anabolic resistance. The response is blunted compared to younger adults, but it is present and clinically meaningful. For the vascular system, resistance training improves endothelial function, promotes angiogenesis, the development of new capillary networks in muscle, and over time improves peripheral tissue perfusion even in the presence of established arterial disease. For the nervous system, resistance training is the primary stimulus for motor neuron sprouting, the process by which surviving motor neurons compensate for those that have been lost. The specific prescription matters. Research in older adults consistently shows that 2 sessions per week, involving the major lower extremity muscle groups, quadriceps, hamstrings, hip extensors, calf muscles, at a load that is challenging but manageable for 8 to 12 repetitions, produces measurable improvements in chair rise performance within 8 to 12 weeks. If you have not worked with a physiotherapist or exercise physiologist before, that is the referral to request, not a gym membership. A supervised program where the load is appropriate, the form is correct, and the progression is monitored. Intervention 2. Protein timing and leucine threshold. The anabolic resistance I described, the blunted muscle protein synthesis response in older muscle, can be partially overcome by 2 dietary adjustments that have strong evidence behind them. The first is the leucine threshold. Leucine is the specific amino acid that acts as the primary signal to activate muscle protein synthesis. Older muscle requires a higher dose of leucine per meal to trigger this response than younger muscle does. The practical implication is that each meal should contain a minimum of 25 to 30 grams of high-quality protein, enough to deliver the leucine threshold in a single bolus. Spreading the same total daily protein intake across 6 small servings, each too small to cross the threshold, produces substantially less muscle protein synthesis than concentrating it into 2 or 3 adequate servings. The second is post-exercise timing. Muscle protein synthesis is most active in the 2 to 3 hours following a resistance training session. Consuming a protein-containing meal or supplement within this window significantly amplifies the training response. This is not a supplementation recommendation. It is a meal timing recommendation. A chicken breast or a substantial serving of Greek yogurt within 2 hours of your session is the clinical guidance. Intervention. 3. Managing the inflammatory drivers. If your hsCRP is elevated and your inflammatory markers indicate chronic systemic inflammation, the conversation about muscle loss does not end with exercise and protein. It extends to the sources of inflammation. In seniors, the most modifiable inflammatory drivers are visceral adiposity, insulin dysregulation, sleep-disordered breathing, and dietary omega-6 to omega-3 imbalance. Each of these is addressable. None of them is addressed by a leg exercise program alone. If your hsCRP is above 3 and your fasting insulin is elevated, you have an insulin inflammatory loop that is suppressing muscle protein synthesis and accelerating cardiovascular disease in parallel. That connection warrants a conversation with your doctor about metabolic management alongside any exercise program you begin. Intervention 4. Vascular risk management, specific to peripheral arterial disease. If your ABI is below 0.9, the intervention picture expands. Statin therapy in PAD patients reduces cardiovascular events by 25 to 30%, but also slows the progression of peripheral arterial disease itself and, importantly, improves claudication distance and lower limb function in patients with symptomatic disease. If you have confirmed PAD and are not on a statin, that is a gap to address. Supervised walking exercise, specifically walking to the point of mild claudication, resting until it resolves, and repeating, is the most evidence-supported intervention for improving lower limb perfusion in PAD. It does not reverse the arterial narrowing. It stimulates collateral vessel development that bypasses it, and it is more effective than angioplasty for improving walking distance in patients with mild to moderate disease. Antiplatelet therapy, blood pressure optimization, and smoking cessation, if relevant, complete the vascular management picture. Let me bring this back to Gloria. Gloria's 30-second chair stand test produced 8 stands. For a 68-year-old woman, the threshold for Warrant's evaluation was 10. She was 2 below. Her ABI was 0.84 on the left leg and 0.91 on the right. Left leg, mild peripheral arterial disease. Right leg, borderline. Her hsCRP was 4.2, elevated, consistent with the chronic low-grade inflammatory state I described. Her grip strength, 16 kilograms, below the 18 kilogram threshold for women her age. 4 tests, all returned within the normal range at her last annual physical, because none of them had been performed at her last annual physical. Her GP had measured her blood pressure, reviewed her lipids, and noted no acute concerns. Gloria had left that appointment reassured. She had gone home and attributed the difficulty with her sofa to the sofa. Here is what changed. Gloria was referred to a physiotherapist with a specific prescription: progressive lower extremity resistance training, twice weekly, with documented load progression. She was referred to a vascular medicine clinic where her ABI was confirmed and a supervised walking program was recommended alongside her GP's review of statin therapy. Her HSCRP was used to open a conversation about her diet, specifically the omega-6 to omega-3 ratio in her daily eating pattern and her fasting glucose, which was borderline elevated and had never been discussed. At her 12-week review, her chair stand test produced 12 stands. She had crossed the normal threshold. At 6 months, she told me she had not used the armrest to get up from the sofa in 2 months. Her daughter had visited and had not said anything. She had not needed to. Gloria said something to me at that 6-month appointment that I have thought about since. She said, "I spent a year thinking it was the sofa. Nobody told me it was me, and nobody told me that me was fixable. Write this down, or stay on this section and replay it. These are the 4 things to request at your next appointment and the exact language to use." Important. Do not skip this. If your ABI comes back below 0.9, do not accept a referral to physiotherapy alone as the complete response. Peripheral arterial disease requires vascular medicine input alongside any exercise program. The exercise is correct and necessary, but the vascular risk management, statin review, antiplatelet discussion, cardiovascular risk factor optimization must happen in parallel. These are not separate problems. They are the same problem seen from different clinical departments. You are the only person in the room who can insist they be discussed together. This is what I do in this channel. I give you the clinical picture that the fragmented structure of modern medicine does not have time to give you in a single appointment. I give you the names of the tests, the thresholds that matter, the language that turns a reassurance into a plan. Your GP has 15 minutes, your cardiologist has 12, your physiotherapist has not met your vascular surgeon. This video just gave you what none of those appointments gave you alone. Before you go, I have one question. How many stands did you get? If you did the chair stand test during this video, and I hope you did, put your number in the comments. Not your age, not your diagnosis, just the number. Because I promise you, someone watching this tonight who scored 6 and is frightened by what that might mean is going to find your comment, your 8, your 10, your 12, and understand that the number is a starting point, not a verdict. If this video gave you something your appointments have not, subscribe. It is free. First link below. And when you write to me, I write back.